The medical management team is a big part of the interdisciplinary team at the medical group. And one of the things that we look at specifically is care coordination.
So the overall goal of care coordination is making sure that the patient gets the right level of care, the most appropriate care at the right time.
We want the process of a patient being referred to case management or disease management to be smooth and to be coordinated well.
And to provide continuity of care and just make sure everything is coordinated for the patient so the patient's not wondering where they go next.
The members of the medical management team are the healthcare integrator, the EFMP coordinator, the case manager, the utilization manager, and the disease manager.
Getting in touch with the disease manager, the case manager, utilization manager, or HCI, depending on what kind of issue the patient has, we're able to just call them or walk them to their office and provide care and coordination for all their services that they offer.
Unfortunately, we live in a day and age that has a large administrative burden and sometimes falls upon the patient. Scheduling appointments, dealing with healthcare insurance and billing, and unfortunately that can get in the way of timely and efficient healthcare. And for that reason, we have our administrative staff that can single out and identify the patients that require that higher level of care and help them coordinate that care to decrease some of that burden on the individual.
It makes their life a little easier, a little less complicated. We make sure that they get to all of their appointments, and that way they are at the best treatment we can get them.
If the patient has fragmented care, a lot of the time things will be missed. But with good care coordination, we're able to keep the patient on the same page, and we're able to follow them throughout all of their care.
An important part of providing effective and efficient care to all patients is care coordination between the PCMH clinical team, the medical management team, and other members of the enhanced access team, such as BHOP or PharmD. Medical management refers to the planning, coordination, and delivery of appropriate healthcare services to chronically ill, injured, disabled, or high-risk patients. It includes disease management, utilization management, case management, discharge planning at inpatient facilities, and the Exceptional Family Member Program Medical. The goal of care coordination is to improve patient outcomes among chronically ill and at-risk patients by providing better healthcare access and quality of care. At the same time, effective care coordination will decrease cost and variation in care management.
Our administrative staff, the disease management staff, and the nursing staff all work together in support to the PCMs to allow us to better identify and deliver that health care in a timely fashion.
Our registered nurses that work with us are actually appointed to a doctor-tech team. So you have the nurse, the doctor, and the tech that always work together. And what's great about that is you really get to know your patients.
They know their patients best. They are the ones that talk to their patients on a regular basis. So they know if something is going on that's concerning.
So the RN has more time with the patients than the provider does. So they'll see the provider and the provider can provide them with education, but then the RN is able to spend more time with the patient because they're not under time constraints of appointments. And they're more of a liaison between everyone, and they know all the services that the clinic has to offer.
If someone needs to have a case manager to help manage their complicated multiple medical comorbidities, we'll place a referral and get in contact with the case manager. If they need a disease manager to help better take care of their diabetes and the multiple issues and education needed with that, again, a referral can be placed, or we can actually make contact through phone or face-to-face to go further into that.
The PCMH clinical team is the core of care coordination. The clinical team knows the needs and risks of their population, and they are ultimately responsible for patient outcomes. They determine the flow of patients in and out of the registry. Patients who are not in the registry are managed by the PCMH clinical team, and the medical management team consults on these cases. Care for registry patients, on the other hand, is managed and monitored by the medical management team with PCMH clinical team coordination. Patients should flow in and out of the registry as appropriate. Coordination between the PCMH team and medical management team is a key element in proactive care of this patient population. Every team member should be aware of who has which patient and what that patient's needs are. Handoffs and transitions of care are key to coordination. Team RNs are uniquely positioned to identify and prioritize high-risk patients for care coordination or referral to medical management. They should also lead patient education efforts by using evidence-based guidelines and teaching resources designed to help patients manage and improve their own health. Techs support care coordination by using tri-service workflow templates to document and track continuum of care elements. They also contribute in the coordination of care by performing within their scope of practice, using clinical support staff protocols, and encouraging patient use of MyCare.
Well, Mr. Walker, with your history of uncontrolled high blood pressure and diabetes, I'd like to set you up with the disease management team. A member of our team will call to set up an initial appointment with a disease manager to go over your medical history and work out a plan of care to better manage your hypertension and diabetes.
All right, that sounds fine.
I'll refill your medications for 2 months, but I want to see you in 6 weeks to see how you're doing. I'll be checking in with the disease manager to make sure we coordinate your care, and I'm also going to put in some lab work for you to complete before our next visit. Do you have any questions?
Just where and when I can get my medication.
Okay, I'm putting them in right now. The pharmacy is located just to the right of the clinic entrance, and here is a summary of the plan of care we discussed today. Please make sure to stop by the reception area to book your follow-up appointment before you leave the clinic.
Great, thanks. Nice to meet you.
You too, sir. Welcome to the area.
We teach patients about their medical condition, like their diabetes, their asthma, high cholesterol, and hypertension.
Screening our patient population, looking for high-interest diseases, chronic diseases that we could better address, looking at our preventative medicine statistics, and helping us generally improve our preventative and medical care for chronic diseases of all kinds.
She provides all the resources available. She does educational teaching. She actually does in-house teaching in a group setting to where patients can actually learn from one another.
Also, it's about self-management. So teaching them, giving them the tools, helping them to make the right decisions, that is disease management.
Oftentimes they will have so many questions, and an overwhelming amount of information sometimes is difficult to absorb. And our disease management nurses ensure that education is continually fed to the patient until we get them controlled under that new diagnosis.
We huddle on a daily basis, at least once, if not twice. And at least once a month we have a review with our disease manager of our patient population, sometimes including specific diseases of interest like our diabetic patients or our hyperlipidemia patients or our hypertension patients.
They know that they have a resource for that and somewhere they can get answers from not only their specialist but also their primary care manager, and optimize that care and give that reassurance to the patient, knowing that they always have someone that they can call and have that those questions fielded or addressed.
Disease management, or DM, is the program of care for patients with chronic diseases. There are 8 chronic diseases that the Air Force recommends as top priorities in DM programs, including asthma, congestive heart failure, chronic low back pain, chronic obstructive pulmonary disease, depression, diabetes, dyslipidemia, and hypertension. The number of disease managers required by the MTF is based on disease burden per 1,500 patients. Patients with multiple comorbidities are only counted once in this formula. The goal of DM is patient self-care. The disease manager collaborates with the primary care manager, or PCM, to identify, educate, monitor, and evaluate patients with chronic disease. The disease manager should then establish processes for the patient to self-manage their disease and educate them on available resources. Because the ultimate goal is patient self-care, the DM program should prioritize patients who are newly diagnosed, especially fragile, or who fall off curve and need re-entry into formal disease management. Care coordination with the PCMH team is critical to ensure patients are receiving the appropriate level of care. The disease manager assesses the patient's needs, their readiness to change, their healthcare literacy, and sets goals for desired outcomes. After a motivational interviewing process, a care plan based on the goals negotiated with the patient is developed and executed. The disease manager monitors and evaluates the patient's progress and uses this information to adjust the care plan. If the patient is making adequate progress, they graduate from the DM program and care can be handed off to the PCMH team. If necessary, the patient can re-enter the cycle of disease management intervention.
The role of the case manager is to help follow our chronic patients with either multiple medical comorbidities or just very severe issues that might need an intense amount of referrals or labs or follow-up to help make the process less confusing and easier for the patient to follow.
Individuals that have chronic medical conditions that require coordination through all spectrums or multiple disciplines in medicine.
Patients come to case management because they're more complicated. They have a lot of problems, a lot of medications, or they have a very serious diagnosis.
Patients that have lots of different referrals, if they're going off base to numerous different places, then they can help assist calling the hospitals, making appointments, and kind of scheduling everything for them.
If the patient will require multiple coordination of care with their specialist that is not in our area, she usually helps those patients make sure that they set an appointment with their specialist, their referral gets approved by TRICARE, and there's no issue there.
That can be all the way from a simple phone call, which could involve just checking up on an appointment, all the way to making a referral happen to a non-participating facility.
They kind of manage all their case from cradle to grave, if you will, as far as their health care to ensure that everything is taken care of. They get the proper care they need, when they need it, and where they need it.
Patients range from cancer patients to, I have several TBIs, and then just an assortment of other things. They can go from pediatric to 90.
We do have patients that have cancer, and we have a tumor registry. So the case manager would make sure that that patient is getting proper care. So this is a small clinic. We're going to do what we can, but specifically, whatever they need to go for treatment, we're going to make sure that case management coordinates that and that they're also getting us the results so that we know what's going on with our patients.
The case manager, or CM, identifies individuals with complex care needs meeting the criteria for CM services. These criteria include patient needs referrals to multiple specialty care providers, catastrophic illnesses or injuries, multiple chronic or terminal illnesses, complex medical problems or dual diagnosis of medical and psychiatric problems, multiple visits to the emergency department, transplant that is high risk or high cost, special interests, such as a high-visibility wounded warrior, functional or physical deterioration, frequent utilization of healthcare resources and services, high-risk obstetrics, HIV/AIDS, severe burns, substance abuse, and extensive coordination of resources and services. The expected caseload for CMs, or the number of patients actually enrolled in case management, is between 25 and 35, but can surge up to 50 at times. Care coordination patients are only enrolled in case management if they continue to require a CM's assistance after 30 days. The CM assesses the needs of the patient and sets goals for desired outcomes. The next step is to develop a comprehensive, cost-effective care plan that enhances access and quality of care. Executing the care plan is the bulk of the CM's work. The case manager coordinates care plan activities with other PCMH team members and monitors and evaluates the effectiveness of the plan in achieving desired outcomes and goals. When the patient transitions to optimal function, the desired outcomes have been achieved, or the needs of the patient change, the CM provides a warm handoff to the next setting or level of care. The patient may transition to another case manager or a non-clinical care manager, such as the Recovery Care Coordinator or the Federal Recovery Coordinator, or they may return to PCM care. Discharge planning, or DP, is a step in case management that encompasses activities facilitating a patient's movement from one healthcare setting to another, or to home. DP is a multidisciplinary process involving physicians, nurses, social workers, and other health professionals. The goal of discharge planning is to enhance continuity and transitions of care.
So the utilization manager is someone who looks at how our patients utilize healthcare, how they utilize healthcare in the emergency room setting, the urgent care setting, and also in-house.
So the utilization manager tells us our high-risk patients are the high utilizers. They track them, and they also obtain all our ER reports from off-base. They have a ton of MOUs with different places and are able to provide continuity of care with our patients here.
The medical home physician needs to know what his patients are being seen for, what medications they're taking.
For instance, if it's a weekend and a patient gets admitted for any kind of medical issue, the provider's not going to know that on Monday morning. So she helps bring that information to the provider so they can ensure that there's continuity of care with that when that patient is discharged from a facility downtown. So the provider can create follow-up appointments, the nurses can get in contact with them, ensure that they have the care that they need, the medication they need, and if it is a serious enough situation, they can bring in the disease manager, they can bring in the case manager as well.
Everything that we do ties in together. We can take care of a patient at one time instead of having them come multiple times.
Our utilization manager helps to minimize adverse events that could potentially fall upon our patient by identifying individuals that had a recent inpatient stay or have a specific pathology that is poorly controlled. We can identify these individuals and get them the care they need.
It allows the clinic nurses to call each of those patients to not only follow up with them, but also to educate them on reasons why they may or why they should have to go to the ER or why they don't.
Seeing referral trends, trying to see, hey, maybe we can do something in-house to recapture some of this care.
We're also looking at high acuity scores. Are these patients appropriate to be seen here at our facility, or do they need to be seen off base? We're looking at cost effectiveness.
So things like asthma or any kind of mental conditions or any specific condition that we need special care for, we want to make sure that our next base that we send our active duty member or the family to has that care available.
The Utilization Manager, or UM, is a registered nurse who uses systematic, evidence-based, data-driven processes to identify and improve clinical and business outcomes in the medical management program. Indicators of ineffective or inefficient delivery of care that the UM might identify include high cost, high volume, or problem-prone diagnoses, procedures, and services, and high utilization rates for services such as pharmacy, outpatient visits, or the emergency department. The UM also determines the medical necessity for the least costly and most effective treatments and directs patient care to the appropriate provider level. They evaluate the quality, risk, and cost of healthcare services and use this information to recommend organization-wide interdisciplinary process solutions. Establishing referral and authorization management processes is also the utilization manager's responsibility. Referral management, or RM, is a subcomponent of utilization management. RM and UM are usually under different chains of command in the Air Force Medical Service, with UM working under the SGH and RM working under TRICARE Operations and Patient Administration, or TOPA. Despite the different chains of command, they should work together to meet RM and UM goals. The Referral Management Center, or RMC, is the MTF's connection with the TRICARE Regional Contractor and Purchase Care System providers. The RMC coordinates and integrates care across all elements of the health system, from subspecialty care to home health and nursing homes. Working with all elements of medical management and the PCMH team is critical for efficient referral management. The Exceptional Family Member Program Medical, or EFMPM, supports military family members with special needs. The EFMPM documents and evaluates the medical and educational needs of family members in order to advise on the appropriateness of family member travel for a PCS. the EFMPM coordinates with the Air Force Personnel Center to ensure that active duty sponsors are assigned in locations that can meet the needs of family members. The program coordinators also work with case management to assist in linking families with medical care after they arrive at the new duty location.
Okay, what's next?
I hope you all had a chance to review the high utilizer report I sent last week. Let's talk about these patients.
I noticed that 6 of the patients on the high utilizer report are diabetic patients, and some have comorbidities. All of them can benefit from disease management. I'll engage with each of them and enroll them in my disease management program. I'll contact the PCM teams they're in panel to, and together we can coordinate a plan of care.
Okay, great. For our minutes, I'll note that you'll be contacting and enrolling the following patients in our disease management program: Mrs. D. Brown, Mr. McGillicuddy, Lieutenant Colonel Steiner, Sergeant Powell, Sergeant Austin, and Mrs. Brandon.
Good. Including these patients in our DM registry is definitely the way to go. Having a dedicated clinic point of contact for these patients may help streamline and make their clinic visits more efficient. It should help cut down on unnecessary appointments.
Speaking of unnecessary appointments, there are 3 patients on this report who not only utilize outpatient clinic services over 15 times a year, but these 3 patients also show an increased trend in ancillary service utilization, specifically in-house and network radiology. I conducted a records review, and these 3 patients do not consistently see the same provider, which may be contributing to the overuse of radiology services and referrals.
Sounds like they need case management, or at the very least, care coordination. Let me conduct a comprehensive records review and engage with the PCM team to determine if these patients are good candidates for CM or care coordination.
Perfect. Once you do that, let us know what their final disposition is.
Will do.
Okay, that takes care of the high utilizer list. Next, let's talk about patients discharged from hospitalization. Ms. Gordon, you have that list?
Yes, here's the list that I got from TOPA. You should all have a copy. As you know, I review the discharge list on a weekly basis. In the last 15 days, we've only had 5 patients discharged from an inpatient setting. Mr. Walker was one of them. He was hospitalized for a heart attack. I've already contacted him. He was discharged 5 days ago. He has a follow-up with cardiology in the network, and Mr. Walker confirmed that. I also made sure that the referral is current in the system.
Okay, great. Let's move on.
So the healthcare integrator is in many cases, the director of the medical management team and or the supervisor of the individuals in the medical management team.
And they help identify ways we can better serve our population, both through preventative medicine and better identifying and following through on our different types of treatment plans for our patients.
I get to look at different metrics every day and kind of figure out how we can make them better by looking at different processes. I get to look and find out, is it something that we're doing? Is it something that the patient's not doing? Is it something the patient is doing and we're not capturing?
They actually provide a second set of eyes. They'll review everything to make sure everything is appropriate, and if something was missed, then we would go ahead and readdress it at that time.
The HCI interacts with the other members of the medical management team. They have huddles, and they're able to, they're tight-knit team, because some of the patients that use disease management, also use case management, are also tracked by the utilization manager as well.
If there's any patients that need anything specifically, as far as screening goes, like if they need to be screened for colonoscopies, if they need to be screened for women's health exams, that we have all of that data. And there's a certain system that we use for that, and he makes sure that the system is always up and running and that we're getting good reports and that we're actually calling our patients and getting them in for those appointments.
Through family practice, the administrative staff, the support staff, oftentimes there can be a disconnect. Our healthcare integrator allows us to bridge those gaps, allows us to identify common themes and seamlessly or synergistically work together to develop a treatment plan that would best suit individualized patient needs.
Group practice manager is basically the gatekeeper of the providers for their scheduling within the clinic. For instance, they help build the templates, which actually keeps the providers on track if they're with the amount of patients that they see, the type of patients that they see, and the appointment time.
So the group practice manager is in charge of the business plan of the medical group.
She makes sure that all of our appointments for our doctors are coordinated, so she helps us get all of our bookings in. Again, we see 18 to 20 patients per provider per day, so we stay very busy.
We focus on the access side of things, so at small clinics we really work with the family health flight commander primarily, trying to keep access within the access to care standards.
They work on all aspects of the delivery team, whether it be the appointment line that's first booking that appointment to the time that they check in. They ensure that the flow is seamless, allowing us to better deliver care in an optimized fashion.
So the GPM, healthcare integrator, need to work together to help balance empanelments, making sure patients are with the correct provider. We also work on collaborating on getting patients who are maybe being seen outside of the MTF back to the MTF.
The Healthcare Integrator, or HCI, under the direction and support of the SGH, oversees the medical management program. They set the direction and priorities for the program to optimize access and quality of care using cost-efficient clinical processes. As part of overseeing medical management, the HCI works closely with the Group Practice Manager, or GPM. The GPM participates in business planning, scheduling, acuity balancing, managing access to care, optimizing productivity, coordinating logistics, strategic planning, and monitoring patient satisfaction data. They analyze processes and data to understand what's working, what needs to improve, and what areas deserve greater focus. The HCI designs, plans, develops, implements, and directs the medical management program. They provide clinical oversight and supervision of the disease management, case management, utilization management, discharge planning personnel, and EFMPM. The medical management team is integral to ensuring the care we deliver to our beneficiaries is always patient-centered, accessible, safe, and of the highest quality possible.
It's important for the clinical team to coordinate with the medical management team so that everyone's aware of all the issues that need to be addressed with each specific patient. And in real time, you can address each specific issue with the PCM as it changes.
So the purpose of all these players, the GPM, the HCI, the case manager, all these people, our team nurses, is to provide good care for our patients. So they all have their own roles to fill in helping us as providers provide the best care we can to our patients.
I feel that without our support staff, we would be at a loss. We would be at a loss to take care of our patients. Those specific needs that would otherwise be either unrecognized or would not be identified are being captured by our support staff, our utilization managers, our disease managers are identifying these patients that would require that higher level of care, and we can deliver it.